I would like to introduce today's speaker, Scott Goodspeed. He is a consultant at Stroudwater Associates, and he has been the president and CEO of 4 hospitals in 3 states and has a deep industry experience and a national reputation in governance. His focus is centered on clarifying strategy, rapid deployment, culture change, and enhanced operational and financial outcomes. Scott is a nationally recognized speaker and has authored and delivered over 500 presentations to various professional associations and healthcare organizations. His most recent book is titled Community Stewardship, Applying the 5 Principles of Contemporary Governance. And he is currently conducting research on organization and board culture for his next book, which has the working title of The Culture Checklist. He received his doctorate in health administration and leadership from the Medical University of South Carolina and his master's degree in hospital administration from the University of Minnesota. So now I will turn it over to Scott to share his presentation, A Strategic Framework for Assisting Rural Hospitals to Move to Population Health.
Hey, thank you, Leslie.
Yes.
I'm just going to make this full screen on my side. So Leslie, what I'm looking at is I don't have the controls to move the slides forward.
Okay, hold on one second. It looks like you logged in a couple times. Do you have the rights now?
I have them now. Tell me how I blow this up.
There's 4 arrows in the top right corner to make it full screen for you.
Full screen. Okay, I got it. So I want to thank Leslie, Kim, Bethany, and Terry Hill at the National Rural Health Resource Center, and I also want to thank all of you for attending. I don't know how many of you saw NBC News last night, but just as a point of reference, Dan Buettner was on. He's with National Geographic, and he talked about some new research on diet, eating habits, lifestyle practices of communities he's identified as blue zones. And I'm going to come back and talk about blue zones. But those are communities he's identified in those places in the world where the longest lived and healthiest people are. So in 2005, he identified 5 of the world's blue zones. The first one was in Nicoya, Costa Rica. The second one was in Sardinia, Italy. The third one was in Akari, Greece. The fourth one was in Okinawa, Japan. And then National Geographic said to Dan, he said, well, there must be one in the United States. And of course, he said, well, we haven't found it yet. But in 2004, they identified one in the United States that was Loma Linda, California. So I want to recommend a couple of resources, and I'm going to have this on my next WebEx at the end, so the WebEx on Friday. But Dan's most recent book that just came out is called Blue Zone Solutions, and it's published by National Geographic, and he talks about blue zones. But what's more interesting from a population health perspective is he's working with a number of communities in the United States. For example, Albert Lee, Minnesota, Naples, Florida, Fort Worth, Texas, to also develop these blue zones. And if you're interested, you can go on the NBC News website and listen. It's about a 3 or 4 minute segment that was on last evening. The other interesting thing is they've got tools on the Blue Zone website. So if you want to determine using one of their tools how long you will live based on their criteria, you can also do that. But one of the things that came out of the research is genes determine about 25% of life expectancy. And what we're going to talk about today related to population health is those 75% of the other things that relate to life expectancy. They also found out in the research that 80% of chronic diseases are avoidable. And they found that true in these 5 original blue zones and then in some of the research that they're doing across the United States. So let me just say that again, 80% of chronic diseases are avoidable. So I spend most of my time with small community hospitals, many critical access hospitals, rural hospitals across the United States. But I also have one very interesting client that I've been working with for about 2 to 3 months now. And the client is based in Maine, and they're a very, very large primary care group overlaid with a number of insurance products. So we're finishing up a enterprise plan with them, and the thing that we talk about with them all the time is not how do you increase market share or volume, but how do we improve outcomes? How do we refer fewer patients to specialists, and how do we work with our primary care docs to do that too, so we get the best outcomes for our patients. So yesterday I was interviewing a medical director who's on the board of this organization, and at the end of the call I asked her, I said, if you could focus on 3 cohorts of people, who would that be? And she said, number 1, end of life. So that should be on your list when we talk about population health. She said the frail elderly, that should be on your list. And she also said I would focus on chronic disease management, specifically congestive heart failure or CHF and COPD, chronic obstructive pulmonary disease. She said within my health plan, my organization, if we could focus on 3 cohorts, those would be them. The other thing I want to mention is I spent a number of years working in Montana with the Frontier Medicine Better Health Partnership, and what's very interesting is they received a $11 million CMMI innovation grant, working with 25 critical access hospitals on a triple aim initiative specifically for Medicare beneficiaries. So for that group of beneficiaries to improve their health status, to reduce their per capita cost of care, and better care delivery. So I would also encourage you, and I will have this on my next WebEx as a resource, to go to their website. It's Frontier Medicine Better Health Partnership, and download. It's a document called CMS Healthcare Innovation Challenge Grant, Frontier Medicine Better Health Partnership. And it was published in February of 2014. It's 49 pages of all the things that those critical access hospitals did with that $11 million CMMI innovation grant to move forward and improve population health. So what's going on across the United States is actually real. I'm going to give you 2 more resources, and again, you don't have to record these because I'll make sure that you get these on Friday. There's another very good book, and Al Lewis is known as the father of population health, and his book is Why Nobody Believes the Numbers, Distinguishing Fact from Fiction in Population Health. It's published by Wiley, and it came out in 2002. It's a rather technical book, but that should be in your library. And then the final thing that I will mention is Managed Care Resources, and you can Google them. So it's Managed Care Resources, Inc. has a list of managed care terms and definitions. I'll tell you it's about 50 pages, but anything you want to know about managed care in terms of the definitions and some of the terminology I'm going to use today, that's a free resource. So let me begin the presentation, and I'm going to open this up for questions as we go. So the dilemma for me and many of the hospitals is that we're living in a fee-for-service world, which may be and may seem and frankly is consistent with population health in terms of how we get paid. The assumption is the way that we're going to increase our utilization, whether it's inpatient or outpatient market share, is we're going to increase volume, we're going to increase share, we're going to increase profitability, and the way we're going to negotiate with third parties, specifically on the commercial side, is we're going to negotiate third-party price increases, and those who are cost-based, of course, critical access hospitals are cost-based. That's how we generate our revenue. When we think of expenses, we've got salaries, wages, benefits. We're concerned about productivity and supplies, but all of this is based on episodic care. So we're going to begin to think a little differently now, and we're not going to begin to think about the kinds of inpatients, outpatients, subacute care patients that come into our organizations, but now we're going to begin to think about covered lives. And those